because a lot of people miss, and a lot of people are not thorough with the basics, why certain things are done and why certain things are not done. So this is basically not picked up from any theory book or anything. This is something which is my experience over the last almost 10 years. What initially I was doing, why I changed to other techniques, and what has happened. So that is what I wanted to practically share with you and understand, so that you will be in a better position to analyze this and apply it in your practice. So, okay. So the first thing is that actually there is no wrong or right way. Like some surgeons may have certain fixed port positions, some may have a certain fixed entry this thing. But no surgeon is wrong and no surgeon is absolutely right. It all depends on what you want to do, how you are doing it. Are you an ipsilateral surgeon? Are you a contralateral surgeon? Or the kind of cases also you're doing. Because after a certain point of time, when you start attempting complicated cases, you'll have to have certain modifications of your own, which on and off I have posted in the group. Like sometimes you just have to reinvent the type of port positions and entry techniques also. So it's basically about how you experiment and adapt to the situations. But in order to keep adapting or being flexible, you need at least one basic system which you can fall upon. Like if it's a simple case, if it's a standard simple case, then you have to actually have a basic technique so that you can fall upon it, so that you don't have to think or apply your brains. Like if it's a straightforward case, these are my port positions, I'm not deviating from this. Be it any case, be it a sterilization, be it a myomectomy, be it a TLH, for everything this is my standard position and entry technique. But if there is some complication or if there is some complicated case, then you may have to adapt, so that if your foundation is strong, it will be easy to adapt. So basically, be ready to adapt, be flexible, and be adaptable. So this is the final picture. There are a lot of people in the group who are listening who know this is the standard port positions or port sites which I have. But how I came to this final picture is what I want to walk you through, so that you understand what is different and why I have arrived at it. So initially I had a lot of doubts, like if it's not a married lady, or if some issue is there, I used to try to go through the umbilicus and all. So I'll take that step one by one. So evolving trend. So basically, when I started my initial career in 2015, I had done a very short course of laparoscopy. So that point of time, the person under whom I trained for a period of 2 weeks, he has the trend of using either the umbilical or the subumbilical area for the central port. So he was very particular about it, saying that most of the cases do a subumbilical thing. If it's not a married, if cosmetic issues are there, then go through umbilical. So initially, I used to use the subumbilical area for the central port. But after a point of time, I evolved from this. Why? Because see, in subumbilical port, the problem is that uh, just a minute. Okay. Yeah. The problem is that the in females, the subumbilical region has got the maximum fat in the abdomen. If you see, always the supraumbilical area, the fat is always less compared to the subumbilical area. This is more evident in females. Men don't have this characteristic. So when we as gynecologists operate on females, this area has got maximum fat. So what happens is that even when you put the Varis needle or the trocar, there is lot of space or lot of tissue between the skin and even the rectus sheath or the peritoneum. So what happens is many a times doctors have a tendency to have this tunneling where you feel you have traveled a lot, but you're actually in the pre-peritoneal or even the pre-rectus area. You keep on tunneling and going inside. So this area is notorious for that. Secondly, most of the previous surgeries we are going to face is either cesarean or an open surgery. And in all these cases, mostly we use fan and steel. So if you put your entry or the trocar or the varus in this area, there is a high chance that you are close to the adhesion area, or you are going to enter some sort of adhesions inside the abdomen. So that is the second disadvantage of this area. Third is lack of grip. If you see that if you try to hold only the subumbilical area and lift, what happens is that because of the extra fat pad there, the tissue keeps slipping. So this is another disadvantage of using the subumbilical area. And the final part is that lacks ergonomy. So I'll come to the ergonomy part when I explain what my other port sites are. Then you'll be able to understand, you'll be in a better position to understand why this position lacks ergonomy, especially for the style of surgeries what I do. So that is why initially, even though I started with subumbilical port, central port, I evolved from there. So the next is actually the umbilical area. So these are the what do you say, characteristics of umbilical area. When I used to go through the umbilical area, even in the initial days for cosmetic purpose and also like unmarried females. So what used to happen is that the umbilicus is not a very easy tissue to deal with. It's always the toughest tissue, toughest part of the abdomen. So even to get a Varys needle through it sometimes was a challenge, and to get a trocar was even more challenging. And what happens is that many a times the umbilical area has got hidden scars. Once it so happened to me that uh, a lady had undergone a previous laparoscopic sterilization, and that history was not properly elicited. They didn't give that history, and even the gynecologist was not able to spot because the tissue, the scar was absolutely inside the umbilical. So we didn't expect that. So once when we went directly through the umbilical area, what happened was that there was a loop of the colon which was adherent to the umbilicus. We directly went and entered the colon, the transverse colon. So it is very possible that even if you don't see a scar in the abdomen, there is a tendency that a lot of people do their primary port site insertion through the umbilicus and the scar gets hidden. So that is when I really thought of it and realized that it's, be it for cosmetic purpose, be it unmarried ladies or whatever, going through the umbilicus is not really worth the amount of effort we are putting in. And these are the adhesions and scars which we are silent adhesions and scars which can be there. And third is a lack of grip. I'll tell you about the lack of grip when I come to the supraumbilical part. And the post-op pain I have realized is much more in umbilical cases compared to subumbilical or supraumbilical, because there is a lot of what do you say, tissue damage which happens there when we what do you say, play with the umbilicus. So because of these reasons, I actually have completely abandoned umbilical entry now. And finally, coming to what I'm doing now is a standard for every case, be it a 16-year-old girl, be it a unmarried lady, cosmetically viable, elderly, menopause, whatever it is. Supraumbilical is the standard site for central port insertion for me. And in a normal case, it is 2 fingers above the umbilicus. That is a standard. If it is, if the higher border or the upper margin of the mass, be it the uterus, be it the fibroid, be it the cyst, if it is above the umbilicus, the dictum is that I go 4 fingers above the upper border of the mass, be it any mass. So standard, if the uterus is subumbilical or the mass is subumbilical, it is 2 fingers above the umbilicus. If the mass exceeds or reaches up to the umbilicus or exceeds the umbilicus, then my standard is at least maintain a 4 finger distance between the upper border of the mass and the central port sites. The advantage of going supraumbilical is that, as I explained earlier, there is least amount of fat in this area for a female abdomen. So the traversing part or the traversing of the Varys or the port site pre-peritoneal or the pre-rectus is minimal in this area. Secondly, most of the surgeries which I've said before are 90% are previous cesarean. Sometimes you may encounter an open myomectomy or open cystectomy or open ectopic. All these cases, the scar is either a fan and steel, or even if it's a midline, it will be usually subumbilical. We don't usually have above umbilicus scars for gynecological surgeries unless it is malignancy, which is rare. So you don't encounter any scars or any adhesions in these areas usually. The best grip, because what I usually do is that I put my left hand on the abdomen, I insert the left thumb into the umbilicus. I use it as an anchor to hold the abdomen and lift it up. So this depression of the umbilicus to insert my left thumb gives me a lot of grip to actually lift the abdomen up. So this has been really, really helpful. In order to increase the grip, you can usually you can use a swab, a gauze piece or a mop there, keep it there and hold it and lift it up. So this acts as an excellent grip to lift the entire abdomen up. And best ergonomy, because I'll explain when come to the port side, because it forms a natural triangle for me with the other 5.5 mm ports and helps me works in the best manner. I am an ipsilateral surgeon, so my major working ports are on the left side, the ipsilateral side, and only minimally use the contralateral side. For this purpose for me, the ergonomy works best when it is in the supraumbilical region. So when the central port increases or moves away from the umbilicus to the xiphisternum, what happens is the accessory port sites also move up. That I'll tell you when we discuss the entire picture. Okay, now coming to the Palmer's point. So Palmer's point is something which I don't primarily use. Palmer's point is only used when the other port sites are not feasible for entry. So that is when I use Palmer's point. Palmer's point, as everybody knows, is actually 3 centimeter below the subcostal margin in the midclavicular line. This is a very useful point. Either if the other port sites are not viable, for example, she has an entire midline scar, or she has got a supraumbilical midline or any sort of scar, for example, pancreatic surgery or gallbladder surgery or any upper GI surgery, she has got a scar supraumbilicus, and I'm not able to touch the supraumbilical area. That is when I'll go to the Palmer's point. I'll insert a Varys needle there. Insufflate. I usually what I do is after insufflation, I don't put in a direct 10 mm trocar. I put a 5.5 mm trocar, use a 5 mm scope and visualize the abdomen and see how the supraumbilical area is. If it is neat and clean, I'll put a 1 centimeter incision there and I'll put a trocar, primary working trocar for the laparoscope there, and then abandon the Palmer's point. Otherwise, if that is not feasible, then we can even continue at the Palmer's point. So as I said, if there is a supraumbilical scar, and another important thing, we find at least I find a lot of patients who have having mesh surgeries in the umbilical, supraumbilical or the paraumbilical area. So at times what happens is you can never predict the extent of the mesh. Sometimes it covers the entire umbilical, supraumbilical and in the infraumbilical area also. So that point of time, it becomes very hard to penetrate these sites. So that is also one of the indications for going through the Palmer's point, because this area cannot be touched or entered. And few times what has happened is when I'm doing a combined surgery with these plastic surgeons, they when I do combined surgeries with plastic surgeons, they say that we want to do a tummy tuck operation. So for tummy tuck operation, they have to actually keep the blood supply of the umbilicus intact and bring it down and give that cosmetic effect. So they say we want the periumbilical area, especially the supraumbilical area, intact so that the blood supply of the umbilicus comes from there. So in these areas, what we have even done is that we have put in we have gone in through the Palmer's point and put the central port at the Palmer's point. That is a 10 mm port we have put at the Palmer's point and kept it as the primary working port and operated also. So those challenging scenarios also we have faced, where Palmer's point is the primary port where the laparoscope and the camera was inserted. So in these special circumstances, I shift to the Palmer's point. Otherwise, I never routinely use Palmer's point as my primary entry point. But one thing you have to be very careful in Palmer's point is that Palmer's point directly overlies the stomach. So if you're going to go through the Palmer's point, keep your anesthetist informed and ask him to put in a Ryle's tube and decompress the stomach as much as possible. Because otherwise, risk or chance of entering the stomach if you're not careful about it. So you need to have a very good coordination with your anesthetist. Just inform him prior that you're going through the Palmer's point. Just to be more careful, just decompress the stomach as much as possible. Okay, so this was about the port sites, central port site. I'll come to the accessory port sites also later. So before going to the accessory port site, I just wanted to say that this entry technique of mine is standard, something which I've standardized over last 8 to 10 years. So initially what I used to do is I said I used to go subumbilical. So when we used to put the Varys needle, first I used to put the Varys needle, wait for the 2 clicks. After the Varys needle inside, we used to put droplets of water on the Varys needle and lift the abdomen to see if there is negative pressure and water is getting sucked in. And then using a distilled water or a saline syringe, we used to aspirate and see whether any content is coming. So this is what I started out with. But after a period of time, after especially getting trained with Dr. Deepak sir, we have realized that the only thing I do now is I put in the Varys needle, here the 2 clicks. After a certain point of time, you'll get to know, experience what a giveaway feeling is. So once you get that giveaway, we just directly connect the gas tube to the Varys needle and switch on the gas. So as I said in the last class, intraperitoneal pressure or intra-abdominal pressure is always negative. It has to be either negative reading, a 0 or less than 10, as low as possible. If this reading is like that, then you can be rest assured that you are inside the intraperitoneal cavity. You don't need any aspiration. You don't need any negative pressure checking. You don't need any content checking. Nothing you have to do. So, but once you enter with the varies, be sure that the varies does not move after that, because some people enter and then leave the abdomen down. So what happens is that there is a natural tendency of the varies to just slip out of the peritoneal cavity into the fat cavity or the rectus sheath area. So once you lift the abdomen, put the varies needle in, until you connect the insufflation cable and it becomes around 10 millimeter of mercury, till that point of time, hold the abdomen steady, because otherwise, till then, there is a chance for the varies needle get displaced. And then, same as I said last time, insufflate till 20 millimeter of mercury so that it gives a very good ballooning effect, and risk for injury is very less. You are creating a lot of space between the organs and the skin. And as you know, the flow rate in the varies needle can never exceed above 3 to 3.5 liters. If it is very high, that means there is some amount of leak
I
at the
think
site of the
oh, she must have called now. We'll 6:30.
yeah. So another thing is that I always use a sharp metal trocar. Like a lot of people ask me whether I use the opti trocar, whether I enter under vision or the no. I have not all that. If the participants can just mute. Yeah, okay, thank you. So I always use a sharp metal trocar, because using a blunt trocar, sometimes what happens is that there is too much of tunneling which happens. Using an optical trocar, optical trocar is something where you are entering the layers under vision. So for that, you ideally require a 0-degree scope where you can perpendicularly see what you're entering. And then, so I have used all these techniques, but I have abandoned them. Standard is varies followed by sharp metal trocar. Okay. Same happens in Palmer's point, just that you have to ensure that the stomach is deflated. Everything else is same. But here only difference is that most of the cases we use a 5.5 millimeter central port initially. We use a 5 scope and visualize the abdomen to see the adhesions. And if the supraumbilical area is clean, we again go through the supraumbilical area with the 10 trocar and the scope. There has been instances where I have had to use even the subhepatic area also for the primary entry. There was one lady who was, I think, around 120 kg. She had severe abdominal omental adhesions, so much so that it formed an entire curtain from the cesarean scar area till the xiphisternum. She had multiple surgeries. Previous years, 2 CS was there, some other cholecystectomy was there, upper GI surgery was there. So it formed an entire, what you say, curtain from the lower area till the xiphisternum. So what I had to do is I had to go in from Palmer's point, operate in this area, do some clearances, and under vision I had to go into the subhepatic area, put a 10 trocar there, and also operate from the other side to finally release. And I couldn't actually release the entire adhesion. So some part of the surgery was done from the left side to the Palmer's point using the 10 trocar as a primary port, and some point of time from the right side subhepatic area. So once you have a foundation thing, you have to adapt to all these situations. It'll get complicated as you keep on operating. And finally, so this is a final picture. This is the first picture I showed you. This just to tell you that how I've evolved to this final standard port positions, what I'm using now since last at least 3-4 years, because I've not deviated. So the central port comes 2 fingers above. I'm talking for standard cases, normal cases, uterine size, which uterine or fibroid or whatever mass size, which is less than umbilicus. My standard port position is 2 fingers above the umbilicus comes the central port. Then the left accessory port sides, the leftmost accessory port side is 2 fingers above and medial to the iliac crest. It's not the ASIS. A lot of people think it's the ASIS or ask me whether it's the ASIS. It is not the ASIS. I go 2 fingers above and medial to the iliac crest. So what happens is that this is slightly more lateral compared to the ASIS position when you take. How it helps me is that it helps me ergonomically, because I won't be able to explain in this manner. When I operate, basically I don't have to bring my hand too medial to access the lateral structures, because I want the port as lateral as possible so that I can always stay lateral to even the lateral most structures. So that is how my first lower left accessory port side comes in. Second port side is absolutely midline between the central supraumbilical port side and the left lower accessory port side. So that is how it is decided, the exact center point. And on the right side, it's at the McBurney's point, usually roughly at the junction of upper 2/3 and lower 1/3. So in cases when what happens is the uterus or the mass or the cyst or whatever reaches the umbilicus or goes beyond the umbilicus, we take 4 finger breadths above the upper border of the margin of the mass as the site for the central port site. So when that happens, what happens is I don't exactly go for the iliac crest. The all other port positions also shift accordingly up. At least 2 to 3 fingers up, it keeps on shifting so as to accommodate for the mass expansion. They will go up and lateral in order to accommodate for the mass size. So, but the basic foundation remains same. You can always expand from that. As they go higher, the central port goes higher. The other ports also go higher and they go out because we have to access the lateral aspect of the mass. In TLH or in hysterectomy, the thing is very straightforward. You just have to cut out the ligaments and make the uterus free. And then it depends on how you want to take the uterus out. It's as simple as that. There is no rocket science in it. Just cut out the ovarian fallopian tube, round ligament, and the the coronal vessels there. That takes out one ligament. Then it is just two peritoneum, anterior and posterior peritoneum is just cut through. It's avascular. Then comes the bladder dissection and push it down. Then the uterine. After uterine, the cardinal and the uterosacral as a conical triangle structure, you cut that. When you keep cutting them, all the ligaments go laterally and the uterus becomes free when you cut the vault and you're. So this is what is happening. So you have to stay lateral to the uterus as lateral as possible in order to get the access. So this is in short about the port positions and the entry technique. I hope I was not very fast. So now I keep it open for any sort of doubts you want to ask based on this or anything else related to laparoscopy. I'll be happy to answer. So was the presentation, what do you say? Was it easy to understand? Have I explained it well? Is there anything more you need clarity on? You can ask anything. Don't feel ashamed or don't feel doubts will be taken in a negative sense. Nothing. This is something an experience what I've shared over the last, I've gathered over the last 10 years through trial and error. So that it's very easy for you to just take it up and follow. This may not be the perfect mechanism or perfect way for you to operate because your ergonomics will be different, your way of operating. If you're a contralateral surgeon, this may not apply for you. It'll be a different technique. Okay, I'll just wait for 2 more minutes. If there are no doubts, either I've explained it perfectly well or either you have not understood anything. Yeah, Nimi madam is asking, has raised her hand. Yes, ma'am, you can ask your doubt.
Hello, Dr. Akshay. In case of entry through the palmer's point, how would you lift the abdomen? Is it the same way as holding the umbilicus?
Uh, Actually, good question. When you go through the palmer's point, it's very difficult to lift the abdomen. It's more of carefully treading and going for the clicks is the only way possible because how much ever you lift using the umbilicus or any part of that, that area will not really get lifted. So you just have to very casually and very carefully go through and experience the clicks and be intraperitoneal. That's the only thing you can do. Maybe just little beyond the, what do you say, below the palmer's point, you can try lifting the skin area, but still the rectus is not going to get lifted satisfactorily.
Okay, thank you.
One more thing I can
And
advise is
about
that, yeah, just a point.
entry at higher points, like for a masses reaching above the umbilicus, do you
Yeah.
put in a Ryle's tube?
Not necessary. I'll Ryle's tube only when usually I use the palmer's point. Ryle's tube otherwise is not really helpful because when you go through midline, the stomach is not actually going to come there. And midline, where you're entering, you have got a better control over the various needle and the port also compared to the palmer's point.
Okay, that's fine.
So one point I just wanted to make and I forgot now is that I know I just missed the point. Something related to the palmer's point. Yeah. don't wait for a case to come where you are forced to put a Palmer's point. If you have to be thorough with the Palmer's point, at least 10-15 cases in simple cases, go through the Palmer's point and practice it so that when an emergency strikes or when such a situation strikes where you have to put the Palmer's point, you're confident in that. Same goes with the retroperitoneal dissection also. Don't wait for a day to come when you are forced to go retroperitoneally and see the ureters and delineate them and operate, because when emergency strikes, you won't be able to do it fluently. Nimi ma'am will actually remember a case where we had a grade 4 endometriosis undetected, where we had to do entire ureterolysis on both sides. So in
Yes,
initial
yes.
days of my practice or experience, at least 80 to 100 cases I have done retroperitoneally. Even in normal standard cases, we used to go retroperitoneally, visualize the ureters, the entire length, visualize all the structures, take the uterine artery at the ligation. So try to practice these things in a simple case so that when an emergency or crisis strikes, you don't have to sweat.
And in some cases in the ultrasound, sometimes we see mild splenomegaly and all. In that
Yeah.
cases, we can confidently enter through the Palmer's point if it's a mild splenomegaly.
Yeah. Spleen usually does not come there. Spleen usually does not come there. It can be, spleen is not told, unless it's grossly enlarged as a major splenomegaly, it's not a problem.
Thank you.
I'll just keep it open for 2 more minutes. If anybody wants to ask something, I'll be happy to clear. Or even share your experience. It does not need to be questions. You can share your experience too.
Hello, Dr. Akshay.
Yes, madam.
No,
Please go
yeah.
ahead.
I was just saying that one surgeon, like I have seen him doing like putting the varus through the Palmer's point, and then doing the insufflation, and then put the trocar through the umbilicus or something like that.
Yeah.
So his thing was like where we can put the varus and do the pneumoperitoneum,
Okay.
so that you're safer.
Okay.
That's what he was saying. So I just wanted to share this thing, like
Yeah.
this is what he was saying, like.
Yeah. Usually what I do is that unless and until there is some scarring or some issue supraumbilical area, I always prefer, that is my standard, that I prefer to go through supraumbilical area. But when I go through the Palmer's point due to any deviations, I always ensure that I put a 5 mm trocar there and visualize the abdominal cavity, and then again shift back to the supraumbilical area itself.
Yeah, was just sharing like what I just saw him doing. So
Yeah.
just
I started the presentation with the fact that there is nothing right or there is nothing wrong. It all
yeah,
depends
true.
how you practice, what cases you do, what style of surgery you have, what kind of surgery you do. It's all depends on, there is nothing right, nothing wrong. We all are learning. It's an evolving phase.
Yeah. So it all comes with experience and then like thoughts and experiences of other people actually. So
Yeah.
as we do, I think.
Just that we should not be fixated on one single technique and try to apply it for all cases. Sometimes what has happened is that there was a patient who was 125 kgs, very obese patient, but her lower abdominal area was quite clear, as in she was not previous surgery or anything. But then we had to put a 5 mm port in the left lower accessory port side, right accessory port side, and in the suprapubic port side, because that was more easy to approach the uterus, and because uterus was small, it was easier to approach the uterus and operate from that area, keeping my main instruments in that area. So abandoned the left upper accessory port site and shifted to suprapubic port site and operated mainly from there.
Yeah. Thank you so much.
Okay. Thank you. Thank you all for the participation. So we'll meet again next Saturday with another topic. Thank you.